Well, thank you for coming on behalf of Nebraska Cancer Specialists. My name is Katie Rue. I'm one of the nurse practitioners with the practice. I've been here for almost 8 years. I started in 2010. It's really exciting to be able to talk about immunotherapy today. I remember the first time we used immunotherapy back in 2011 when it was approved. There was one drug, it was approved for one type of malignancy, and we were all very scared but very excited to see how it would work for that patient. And since then, it's just been really amazing to see how many patients were actually able to use various drugs for different types of malignancies. So thank you for being here. So I'm going to start by showing a video.
Immuno-oncology in cancer. You may already know about some of the treatment options available for cancers, such as surgery, chemotherapy, radiation, or targeted therapy. There is an additional way to treat certain cancers: immuno-oncology. Immuno refers to your immune system. Immuno-oncology uses drugs known as immunotherapies that target your body's immune system to help fight cancer. You might be wondering, how does immuno-oncology work? Here's an analogy. Imagine that your body is a garden, and the soil is your immune system. The immune system is your body's natural defense against diseases like cancer. Cancer cells are like weeds in your garden. When you're healthy, the soil is rich and well-tended, and able to control the weeds. But sometimes the soil allows weeds to grow and spread. And soon, the entire garden suffers as your plants compete for space and nutrients. Immunotherapy is like adding weed control fertilizer, which enriches the garden's soil. Now, the soil can help keep the weeds under control. So, how is immunotherapy different from other cancer treatments? There are a few ways to control weeds, just like there are different ways to treat cancer. All treatments, including immunotherapy, can potentially harm good plants while trying to restore health to the garden. Let's look at the different treatments. Surgery is like removing a large patch of weeds and the soil around them. Chemotherapy is like spraying a general weed killer over the whole garden. Radiation is like increasing the power of the sun with a magnifying glass to target and dry out the weeds. Targeted therapy is like spraying weeds directly with weed killer. Immunotherapy is different because it targets the soil and not the weeds. This helps restore the health of the garden by enriching the soil to help control weeds. Side effects you may experience will depend on the immunotherapy you are taking and how your immune system reacts to that treatment. Side effects are possible during or after treatment. Since your immune system takes care of your whole body, side effects can happen in many of your organ systems, some of which may be serious. Ask your healthcare team about the treatment options available to you.
I'm going to start off by reviewing some of the most common immunotherapy drugs, and you can see that there's a lot of indications for each one of them. Ipilimumab or Yervoy is indicated for the adjuvant, meaning that you had surgery primarily before the cancer mass was removed, the melanoma in this case, and you're giving adjuvant after surgery immunotherapy to train your immune system to go after any cancer cells that were left after surgery, any microscopic cells, and to train your immune system to go after cells in the future, hopefully. We also use it in the metastatic setting for melanoma. Nivolumab or Opdivo is also used for melanoma, as well as metastatic non-small cell lung cancer, squamous cell carcinoma of the head and neck, liver cancer, certain types of colorectal cancer, metastatic kidney cancer, metastatic bladder cancer, and classic Hodgkin's lymphoma. Pembrolizumab or Keytruda in the metastatic non-small cell lung cancer, similar indications, gastric cancer, metastatic melanoma, certain types of microsatellite instability, high cancers, advanced cervical cancer, head and neck, metastatic bladder cancer, as well as primary B-cell lymphoma. There's Tecentriq for metastatic non-small cell bladder and urothelial cancer, and then durvalumab or Imfinzi. This is one of the newer ones. It's given for people with unresectable, meaning surgery can't remove it, stage 3 non-small cell lung cancer, or locally advanced or metastatic bladder cancer. So your immune system has a big role for many systems, especially in the malignancy type setting. It protects healthy cells from infections and diseases, and it certainly prevents unhealthy cells from growing out of control. Normally you have healthy cells in your body, but sometimes there are unhealthy cells like cancer cells. The immune system has the ability to recognize foreign threats like viruses, bacterial illnesses from normal cells, normal liver cells, normal lung cells. Two components of the immune system are the innate and adaptive immune system, and they work together as two sets of self-defenses against foreign threats like cancer. Your innate immune system is the one that immediately recognizes that, hey, there's a bug or a foreign body or something that's a threat, and it recognizes that and it goes after it right away. The adaptive immune system is a little bit more complex. It's less on the scene, but it does have the ability to remember those particular threats. And should those threats become a problem again in the future, it's those adaptive immune cells that go after that, that foreign threat. Cancer cells have mutated from normal cells, and they can be recognized as foreign by both the innate and the adaptive immune system. So I'm going to give you guys a handout because it's a really easy way that specifically talks about what immunotherapy does and actually how it goes after cancer cells. We'll go through it on the handout itself. So the immune system in cancer, you can see on the cell guide that there are healthy cells, there are unhealthy cells, and then the immune system has its own type of cells, detector cells and fighter cells. And so those are going to be key points throughout this handout. So on the second page, like we said before, the immune system can protect healthy cells from infections and diseases, and certainly unhealthy cells from growing out of control. You can see things like viruses and bacteria are detected by the detector cells and the fighter cells. They travel throughout your whole body, and they look for threats, such as viruses, such as bacteria, and certainly cancer. Normally, when these detector cells find threats, like cancer, they become alerted. So you can see that it has a little, what we call checkpoint on the alerted cancer cell, that little flag that's there. And so that cell is turned on, and those alerted detector cells call in the troops, they call in the fighter cells to become activated as well. So you can see on the top illustration that that alerted detector cell finds a fighter cell, those two different types of the immune systems working together, and that fighter cell becomes activated. So those activated fighter cells go after the threat. They seek it out, they find it, and they destroy it. In this case, they destroy those cancer cells. This is a very complex interaction, and our immune system is a pretty complex system. And this is happening in our body all the time, whether it's a cancer cell, whether it's a virus or a bacteria or some sort of bug. This is happening all over our body and always has been. So you can see at that last illustration, the detector cell fights the cancer cell, it's alerted, and then it destroys it. So one way that cancer is aggressive and becomes malignant is its ability to trick our immune system. Cancer cells can change the way your immune systems react to cancer cells. So the tricky cancer cells evade this very complex process, and they do so in a variety of ways. They change the way they look. They can develop certain mechanisms where they essentially hide from our fighter cells and from our detector cells. When this happens, the detector cell doesn't become alerted. and it can't recruit the fighter cell, and the cancer cells are allowed to multiply and grow. Over time, if this happens frequently and continues to grow and mutate unchecked by the immune system, the cancer cells multiply into a cancer mass. So we'll flip the page here. So in this next area, we're going to talk about how immunotherapy works, how the tumors can respond to different immunotherapy, and the possible side effects. So we'll flip the page. So there are certainly different types of immunotherapy. They all help the immune system act in different ways. We know that cancer cells can go undetected and escape detection from the detector cells and the fighter cells, allowing them to grow. It's in this setting that the immune system may need help identifying the cancer cells and help going after the cancer cells. And that's where immunotherapy comes in. Immunotherapy helps your immune system fight these cancer cells that were previously undetected. They can help activate a fighter cell. They can help identify a cancer cell. And they can help an activated fighter cell go against the immune cells. Now, when we saw in the video, if you can think of your immune system like garden soil, the immune therapy acts like fertilizer. So it helps strengthen all of the soil. And in doing that, the immune system is and has the potential to go after other tissues in our body, tissues that aren't cancerous, our lung, our colon, our skin, our liver. We're going to talk about the side effects of that because it's a systemic treatment. That's where the side effects do come from. One key difference between immunotherapy and chemotherapy is how it works. Chemotherapy acts on fast-dividing cells, which are cancer cells. They're rapidly dividing, so it goes after. And then also fast-growing cells are the cells of your bone marrow, so your red cells, your white cells, your platelets. So systemic chemotherapy affects all those rapidly dividing cells. Immunotherapy varies a little bit different, or is a little bit different. Some immunotherapies stop the cancer cells from escaping the detector cells. That allows the detector cells to become alerted. Immunotherapy can stop the cancer cells from escaping the detector cells, and this is where you can see it's allowing the detector cell to become alerted. Other immunotherapies help the fighter cells stay activated, so that these activated fighter cells that were otherwise turned off or not recognizing the cancer cells somehow became deactivated by the cancer cell. We give immunotherapy, and these fighter cells are activated again to go after the cancer. There is certainly more research being done to see how these immunotherapies may help your immune system fight cancer. I know we had talked about clinical trial opportunities. Just in the 8 years since the first drug for metastatic melanoma came out, you can see we have, many more drugs with certainly many more indications. And so that's a really exciting area of research. So moving on to the side effects. Do you guys have any questions about those slides? Make sense, not make sense? Okay.
Yeah, makes sense.
Okay. So the side effects that come from immunotherapy are different. They can occur within a couple of months after your first treatment of the Keytruda, of the Opdivo. They can occur months after even stopping the drug, to years after stopping the drug. They're just different. And so those side effects are called immune-mediated adverse reactions. We know immuno-oncology therapies boost our natural defenses, our immune response, to fight cancer. Sometimes this will result in our immune system attacking healthy cells along with the tumor cells. And so nearly every cell can be affected by the immune response. Collectively, any side effects from immunotherapy are termed immune-mediated adverse reactions. The most common adverse reactions that we see, I always tell patients when starting off on this during our education sessions, you're going to look at this and go, gosh, this sounds really scary. A lot of these scary things can happen. What ones do I need to worry about the most? And I say all of them. But however, the two most common side effects that we see fairly early on, and it can persist throughout the duration of treatment, are fatigue and a very mild rash. So the fatigue is hard for patients to be okay with. They've already gone through the diagnosis, a staging workup, maybe surgery, maybe radiation, maybe chemotherapy. The fatigue is generally mild to where they can still live their normal lives. What we see usually, though, is that their energy level gets a little bit better. They've come after treatment, so maybe they're used to having nausea, maybe they're used to having anemia, needing blood transfusions quite a bit. We don't see what we call the myelosuppression or the dropping down of your red cell, white cell, and platelet levels. So typically the blood counts go up, and that alone can make patients feel pretty good on this immunotherapy, despite the fact that it does cause fatigue. We can see muscle aches and pain. In terms of the rash, you might notice a little bit of an itchiness to your skin. It's usually not even red. Lotion can help. But it's there, and it's kind of a generalized rash or pruritus.
What's MSK?
Musculoskeletal. We can certainly see diarrhea. That's one of the more concerning side effects because it can lead to dehydration and electrolyte abnormalities. Nausea, difficulty breathing, a fever, a headache, and abdominal pain. So I'm a patient or I'm a caregiver. I'm on immunotherapy. My loved one is on immunotherapy. What do I need to know? It's generally very well tolerated, and I mean that wholeheartedly. Like I kind of alluded to earlier, most of the time, patients that are started on immunotherapy, they're beat up. They're beat up because they've had radiation or surgery or a combination of chemotherapy, and they're still dealing with side effects. While the side effects are serious and nothing to downplay here, most of the time patients feel pretty good on immunotherapy. They can be moderate or even life-threatening, and we'll talk about that. When we start patients on immunotherapy, you at times will meet with a PA or a nurse practitioner, and they'll go through a whole information packet. A lot of times the nurse on your first day of treatment will go through some of the similar information. Certainly letting a nurse know, letting your physician know, letting a mid-level provider know if you have any concerning side effects. And that's while you're in an office, maybe getting the treatment or with a phone call or even on the weekend. The approach to treating these immune-mediated adverse events is very different than traditional chemotherapy. On traditional chemotherapy, if you have nausea, you can take, a Zofran or a Compazine. And while that's still true, for immunotherapy, things like the diarrhea, things like harm to your kidneys or liver are treated with steroids. And the reason we do that is that when we put people on steroids, it essentially puts a brake back on your immune system. Your immune system is really ramped up to go after the cancer, and along the way it can be harmful to your liver or your kidneys or your colon, and you get lab abnormalities, or you can get quite a bit of diarrhea. And so when you come in for treatment, you can expect that you're going to get a full set of labs. And we do wait for all those labs to come back before we give that cycle of treatment. And the reason is because we want to make sure that your kidneys and your liver and the rest of your electrolytes are not abnormal before we give you that immunotherapy. If they are, we definitely don't do away with the immunotherapy, But we do strongly consider at the very least a delay in treatment. That could be a week, that could be 2 weeks, could be up to a month, depends on the severity of the side effect. We may also consider putting people on a dose of steroids, and they're usually a bigger dose of steroids, but those put the brake back on those activated T cells. And so we put the brakes on and we wait for those side effects to improve. And oftentimes they do. Another important thing is to let other healthcare providers know. We always use the ER example. If you end up in the emergency room with diarrhea or with lab abnormalities, we recommend bringing that little card that many of you guys have or your loved ones have with your doctor's name and the name of the drug, because those providers may not recognize that what is going on here, say it's the diarrhea, is treated differently than diarrhea from another cause like chemotherapy. And so just being, making your other healthcare providers aware of the type of treatment you're on helps them easily recognize or potentially recognize these side effects and get you on the right treatment. Oftentimes they'll call our office if it's during business hours, or they'll contact our on-call provider who will recommend steroids and occasionally a hospital admission or close monitoring for that. If the side effects do persist despite steroids, despite holding the drug, sometimes we have to stop. One difference between immunotherapy and chemotherapy, for example, is that there aren't dose reductions. Sometimes we'll give chemotherapy at a lower dose if the patient is having some difficulty with side effects, just to keep them on treatment, and hopefully at the lower dose those side effects will resolve. With immunotherapy, there is no dose reduction. It's a flat dose. We delay the treatment for a week, a month, maybe longer. We treat people with steroids, higher doses at first, and then we try to taper those steroids down. Steroids have their own side effects, but they're the treatment for immune-mediated adverse events. To hopefully the side effect resolves on a lower dose of steroid, and then we're able to pick up that immunotherapy again. Many times that side effect doesn't recur. So, maybe you had some colitis, hepatitis, nephritis, the treatment was delayed for a period of time, the patient went on steroids, we tapered those steroids off for, anywhere from 2 weeks, I've seen it up to 8 weeks. We get the patients down to a minimal dose of prednisone, typically 10 milligrams per day or less. We give them the same drug again, and they do fine. So it's just those different treatment approaches. Our goal is to use this treatment as long as we can, and as long as it's helping your immune system go after the cancer. We'll still do the same sets of scans, if it's CT scans or PET scans, at intervals of anywhere from 3 to 4 months, just to assess for that disease response that we're hoping for. Another thing to remember too is that the side effects can occur certainly on treatment, but even months after stopping treatment. And that kind of goes back to our two different immune systems. The innate immune system, which is the first on the scene to go after the unhealthy cells. Those immune cells don't have memory, if you will. The adaptive immune system works together with the innate immune system, and it's the adaptive immune system that does have memory cells. And so that's why the side effects can persist even when we stop treatment.